Welcome everybody, and welcome to the online audience, to those of you who are joining remotely. This is going to be the first attempt of GIEQs to do a course on gastroscopy. So we've done loads of stuff on polypectomy, we've done loads of stuff on colonoscopy, we've done loads of stuff on training, and lots of other, but actually we've really never done a course focused on the practice of diagnostic gastroscopy. So that's what this is going to be about. That's what these 2 days are going to be about. And we have a really full program ready to go for you to get involved and to enjoy and to catch up on later. So the first thing to do, I think, is to introduce the people around me. And that means we have a full room here in Ghent of people who are going to participate live. We've got people already on the online, on the website and on the Zoom. So all of you can hopefully participate as well. And if you want to ask questions or whatever you want to do, then jump into the Zoom and put them on the chat. Please don't start your video and don't share audio, which is actually blocked. Just put it on the chat and one of us will pick it up and we'll discuss it with everybody in the thing. So the first thing I want to do is we've talked here in the hospital about the ground rules and things about doing the procedures. We have got, I think, about 5 or 6 live cases per day. We've got interspersed with that some lectures and some we call them vignettes, so discussion points. We've got some videos which the participants here today have watched and will discuss, which make different points about gastroscopy. And throughout the day, we will try to give you, or after 2 days, we'll try to give you a structure about how you can think about diagnostic gastroscopy. So the first thing I want to do in 10 minutes is talk to the people who are here and talk about expectations of what they're planning to get out of the course. And then we'll jump straight into a introduction by Roland, and we'll talk a little bit about things pre-gastroscopy before we get into the first patient. So I want to first thank and welcome John Anderson and Roland Valori from the UK. They're two people who don't need introducing to the GIEQs project, but they're both gastroenterologists in Cheltenham in the UK. My name is David Tate. I'm a gastroenterologist in Ghent in Belgium. I'm also joined by David van der Poorten, who maybe give a wave, David. He's a gastroenterologist who trained me in Australia, and he's visiting for many different reasons. But one of them is to participate in this course. So, David, we really welcome you here to Ghent, and we're really grateful that you're here. And hopefully we can get a lot out of these next 2 days. Okay, so let's just go around the room then, starting with you, Tamás. And I would like you to just tell me in a couple of words, something about gastroscopy that you find challenging. That's number one. And number two, of course, introduce yourself. And number three, maybe say what you're planning or thinking you might get out of the next few days. Hit it.
Hi, everyone. I'm Tamás Tornai from Hungary. Currently lucky enough to work in the University Hospital of Ghent. Gastroscopy I find really interesting, especially from the date that I first found an early gastric cancer. And GIEQs had a huge impact on how I have found that. GIEQs 3, especially last year. I just found that case after GIEQs, like in a month, and from that on, I try to be more focused. My examination is more focused, and I'm here to really improve my skills further. The lesion assessment, risk assessment, the technique. Yeah, these are my goals to improve it.
Yeah. Thanks, Tamás, very much. Nice to meet you. Piet-Jan?
Yeah, hi, I'm Pieter Helm. I am a fellow here in Ghent. I think I have a bit the same expectations, but especially like detecting pathology in the stomach. I think inspecting the stomach and detecting pathology in the stomach, especially very subtle changes, is still quite difficult. You need your time, you need the good circumstances, so I hope to get that out of it.
Thanks, Piet-Jan. Michele?
I'm Michele Montori. I'm from Italy, and my expectations for the course are also a bit the same of Tamás and Piet-Jan, but also to learn how to inspect the GOJ and maybe to do it in different way with different technique.
Perfect. Welcome and thank you. Sophia?
I'm Sofia Ridolfo from Italy. I'd like to improve caudal visualization above all in the stomach. In Italy, most of gastroscopy aren't in a deep sedation, so it is very important to not miss cancer.
You said that most gastroscopy in Italy is not under deep sedation. Yeah, okay. So not under propofol. Yeah, okay. So some tips for that we will definitely be putting out, although our cases will be under propofol. Okay, Nika?
I'm Nika from Ghent. I'm a resident in my 5th year, following my education here. But I think it's challenging in gastroscopy is improving the patient's tolerance to be able to visualize the stomach well. Yeah.
So again, you also want some tips about how to do non-sedated gastroscopy and do it well. Okay. And improve your visualization. It's interesting that you're all saying the same thing, but you're only touching on one very small part of gastroscopy. That's very interesting. Yeah, tell me, Alex.
Hello, I'm Alex. I'm from Essex, England. My expectations is that gastroscopy technique can improve the technique and make it as comfortable as possible for the patients, and also to detect very subtle lesions that sometimes might be missed.
Mm-hmm. Thank you, Alex, and very much welcome to you to Ghent. Tell me, Jolien.
I'm also an assistant in training here in University of
What year of training are you in, Jolien?
In gastroenterology.
What year?
What year? 6th year, last year.
Yeah.
Yeah, I think everyone already mentioned the risk assessment and lesion detection in gastroscopy. Improving visualization is, I think, something I want to focus on, certainly in patients who are not sedated and more difficult areas like the incisura or the GI junction in retroflexion. For me, that's not always very easy to perform, so that's something I would like to improve or focus on.
Okay, thank you, Jolien. Duffy?
Akita, I'm my 5th year. And I have like the same struggles that have been mentioned before, the tolerance, because most of the gastroscopies are insulated, and also the retroflexion, the gastroscopical junction, distinguishing like, is it a barrette or is it like hyperinflation of the hernia?
Mm-hmm.
Is also something I struggle with, and like subtle lesions, like is it just an old ulcer that is healing, or is it something more? Something I really struggle with. Yeah, that are the most struggles I experience.
I think so, the something nothing thing is a really important one that I think we can really bring out.
Overshooting biopsies.
I think we can answer that one now. It's probably never overshooting to do biopsies, but yeah, we can definitely get into that. David, do you want to introduce yourself briefly and say, where you're at and something you find challenging or that your trainees are finding challenging with gastroscopy?
Yeah, so I'm David Vanderpoorten from Sydney, Australia. Thank you for having me here.
You're welcome.
I think what you said, David, is really key, that there's very little systematic teaching of gastroscopy. We spend a lot of time learning about how to assess polyps, how to do colonoscopy, how long you have to come out. No one really talks about that systematically for, what is the ideal gastroscopy? How long do you spend in each area? Where do you clean? Where do you look? Where do you biopsy? Do you biopsy repeatedly when it's been done before? I think there's a lot of basic stuff that's really helpful. And as everyone else said, just also really being able to detect what's important and what's not, so that you don't miss things, which, you very much can do.
Perfect. Thank you so much, and again, welcome. John and Roland, you want to give your 2 cents about your things you find difficult quickly, and then we'll move on to Roland's presentation. I think we nearly have a patient ready as well, so yeah.
Okay, so I've previously said on GIEQs 4, I think that the gastroesophageal junction, I find a real problem, especially if there's inflammation there. And I just want to make the point to those watching. They're probably wondering what the hell we're doing at the moment, asking everybody what they need to know. But really, the first step to improve is to try and reflect on what you're not doing well and try and find an answer to the problem you have. Of course, some people don't know that they're not doing it well, and they need someone else to point it out. So hopefully there may be some things that you see today that you will not have considered previously and might help you change your practice. So GOJ is my weak spot, David.
GOJ. Okay. John?
Hi, David. For me, I think the biggest change in my practice has really been the level of sedation. There'll be a spread of practice across this, people dialing in everything from unsedated, you're just using a throat spray, through to what was called conscious sedation, through to full propofol, I would have thought. And my practice has swung very much towards a much deeper sedation. We don't have the advantage of having propofol, but if I did, and I had to choose it for an endoscopic procedure other than ERCP, it would be OGD rather than colonoscopy. I think unless the patient is calm, it's very, very difficult to evaluate things. And it moves me on to the second point, which is if you're going to pick up subtle pathology, and actually it's probably more difficult in the stomach than it is in the esophagus, because the esophagus is straight and tubular. And even if the patient is agitated, you have half a chance of seeing it. But in the stomach, it really is like an earthquake going on. If the patient is retching, you can't get rid of fluid, everything's moving, very, very difficult to assess. And it's no surprise to me that we still lag behind, in particular Japan, in our ability to detect early lesions in the stomach.
Okay, John, great, fantastic. And the other person I need to introduce, but is not yet here, is Lobke de Zomer. She's a gastroenterologist in Roeselare, and she will be joining us shortly. Okay, well, I think we have a patient ready. So what we will do is, Roland, I will let you switch out. I will switch out the screen sharing so that you can do your introduction while we just get the patient ready. But if you just give me 1 second to arrange that. So the first patient in the room is just a patient who's having a gastroscopy, and I think he's had a previous gastroscopy that showed reflux. He has still got some symptoms, so this is a check procedure. So the first person to do it will be Jolien, and Jolien will go to the room, and Lobke will join you in the room to do it. So if you don't mind, go to the Narcose 2. Everybody needs to have all the PPI on for the procedures, please. So that's HAD and all this stuff, but they'll do that in there. And yeah, get yourself ready for discussion. Okay, Roland, over to you.
Can you see my screen there, David?
We can very perfectly see your screen, yeah.
Fine. Okay, so if you want to hop to the room halfway through, just tell me. I'll be about 10, 15 minutes here, okay?
Yeah.
So just 2 weeks ago, nothing to do with this course, one of my colleagues who's just taken over training sent these images of the esophagus in 2 different patients who were reported to have the same lesion in their esophaguses. And basically, this second patient, this first patient had an inlet patch, that's pretty obvious, but the second patient had a further endoscopy 9 months after this one, and a lesion which was visible at the time has become more visible, and with the help of MBI on the right, it's pretty obvious something's going on there. And basically this patient had some biopsies of that lesion. You can just see it appearing here, and we come back a little bit further and we see that the patient probably has got an inlet patch, but this is the area of interest here. And this was a high-grade squamous dysplasia, which has been treated endoscopically. So this patient probably dodged a bullet, assuming that treatment is successful. Now, if we go back not very long ago, there was a lot of cynicism, and I think there still is, about whether we can improve outcomes from upper GI cancer. Certainly, I was probably in this camp until GIEQs 2, and I had a seminal moment where I was listening and watching how a modern endoscopist inspects the esophagus and stomach, and I was quite blown away, and I realized that I'd been left behind, and if I can be left behind, then many other people can as well. So the reality in this day and age is that we are certainly missing an opportunity I think, to improve outcomes of upper GI cancer. I think we know now that if someone has low risk symptoms, the risk of cancer is very low. And the point there is we need to stop doing endoscopy in these patients. The dwell time of cancer, unlike bowel cancer, colorectal cancer, is very short. And we are seeing late diagnosis and failing to prevent cancers. And this is absolutely catastrophic for patients. And we know that we can now pick up early lesions and prevent cancer. Now, this is very important from a health economic perspective. We see that if we have an intervention which is high cost and low benefit, health economies will not be willing to pay for it. But if we're doing a lot of high volume, low value endoscopy, it's going to be very costly with little benefit. And what we need to do is we need to do less colonoscopy and endoscopy, and we need to be doing it much better. And we have an opportunity there to save money and improve outcomes. Now, this isn't just the payer's perspective. If you're a patient, you'd really want this yourself. You don't want a painful, nasty endoscopy when you're 25 and you've got low risk symptoms. And if you're 75 and you're a smoker or you're high risk for some other reason, you want a really good endoscopy. So how big is the problem? Now, this is very important from a health economic perspective. We see that if we have an intervention which is high cost and low benefit, health economies will not be willing to pay for it. But if we're doing a lot of high volume, low value endoscopy, it's going to be very costly with little benefit. And what we need to do is we need to do less colonoscopy and endoscopy, and we need to be doing it much better. And we have an opportunity there to save money and improve outcomes. Now, this isn't just the payer's perspective. If you're a patient, you'd really want this yourself. You don't want a painful, nasty endoscopy when you're 25 and you've got low risk symptoms. And if you're 75 and you're a smoker or you're high risk for some other reason, you want a really good endoscopy.